On behalf of everyone in our UCLA community, it's my great privilege to welcome you, the extraordinary team of doctors and nurses and staff who have performed the first hand transplant west of the Rockies. We will also, for the first time, publicly acknowledge the brave young woman who was the recipient of the transplant. It is also my great pleasure to introduce to you our Chairman Extraordinaire, distinguished Chairman of our Department of Surgery, Dr. Ron Busuttil. Dr. Busuttil.
Thank you, Dr. Washington. Good morning, ladies and gentlemen. This is truly a signal event for all of us at UCLA and certainly our wonderful patient. It really gives me great pleasure to welcome you to our news conference to recognize both the extraordinary medical team and our extraordinary patient. They participated together in this landmark surgery at UCLA, and as Dr. Washington mentioned, this is the first hand transplant that has been done in the western United States, and it is also the 13th hand transplant that has ever been performed in America. If we can put this into perspective, to perform this remarkable procedure, it took a dedicated team of 17 UCLA surgeons, transplant physicians and coordinators, anesthesiologists, operating room nurses, and technicians, all led by Dr. Cody Azari, the surgical director of UCLA's hand transplant team. This surgical tour de force took 14 hours, starting just before midnight on March the 4th of this year and ending at about 2:30 p.m. the next day. To perform this procedure, it took a year of planning to lay the groundwork to assemble this multidisciplinary team, along with all of the resources required for this historic medical breakthrough. All aspects of the recipient and donor procedure had to be perfectly orchestrated. In fact, identifying a donor with a compatible hand for a transplant is certainly much more difficult than identifying a donor for instance, a liver or a heart. When the news came that a match had been found, our patient was immediately flown from her home in Northern California to UCLA. While doctors prepared her for the transplant, our organ recovery team flew to San Diego, where the OPO organization named Life Sharing worked with the so generous family of a deceased donor to arrange for the donation. At midnight, one team surgically exposed our patient's amputated limb, while a few feet away, Dr. Azari and the remainder of his team performed a mirror operation on the donor hand. After several hours, the transplant surgeons began melding the two limbs into one. At this time, our UCLA team would like to take the opportunity to recognize and truly thank the donor family of this very precious gift. Since April is Donor Organ Awareness Month, I wish to emphasize the importance of organ and limb donations. Some are life-saving, as you know, and some, such as the gift that Emily received, are life-enhancing. And now I'd like to introduce Dr. Cody Azari, Surgical Director of the Hand Transplant Program, who will personally recognize the invaluable members of his team. Cody, could you please come up?
Thank you, Dr. Busuttil. I think the operative word here is team, because hand transplantation is not about one person. It's truly a team effort, and it begins, as Dr. Busuttil says, several years before the actual procedure. It involves the melding of multiple disciplines that in other ways would never have connected with each other. Hand transplantation is a new frontier, yet hand surgery is not new, neither is transplantation medicine. Yet for this amazing operation, the two fields united. We have been putting a team together to put this operation for, as I mentioned, several years. It doesn't just involve surgeons, it involves myriad of other disciplines, from neurology, hematology, psychology, brain mapping, infectious disease, transplantation medicine, orthopedic surgery, plastic surgery, rehabilitation medicine, and really the team goes on and the list goes on. So there were at least 40 physicians and major individuals involved in performing this operation. As I mentioned, it's about a team effort, and what's most important to me is to recognize the team and the patient, Emily, and you'll get to see her in a few minutes. Let me begin with the team, and I'll start from my right. It begins with Dr. Scott Mitchell, who is one of my esteemed colleagues. He's one of my partners. He's an orthopedic surgeon and also a hand surgeon. Next is Dr. Prosper Benheim, and I'm proud to say that he's been my mentor in hand surgery. Dr. Benheim is the chief of hand surgery at UCLA. Not only is he a hand surgeon, he's also a plastic surgeon. Dr. McDermott is part of the team, and I'll introduce her a little bit later on. Dr. Crisera is a microvascular surgeon and a reconstructive plastic surgeon. Dr. Fostekjian also is a microvascular surgeon and reconstructive surgeon and plastic surgeon. So is Dr. Zhang sitting next to him. These individuals were the force that gave the hand blood, they were the force that gave the hand life. Next is Dr. Patel. Dr. Patel had a very significant part in this operation where she was leading the anesthesia efforts. That's critical in that to get the patient through the operation very smoothly, safely, and in a very healthy type of way. And finally, and last but not least, is certainly Dr. Tim Miller, who is a world-famous hand surgeon as well as a plastic surgeon. In fact, Dr. Miller is the chief of plastic surgery at UCLA. But the team still goes on. There were other anesthesiologists that certainly need to be recognized, and one is Dr. Zadeh, who is unfortunately not here, and Dr. Stedman, who is the chief of liver transplant anesthesia. Then there were the nurses. If you think we had a hard time on a 14-hour operation, the nurses, which are sitting here by the name of Christina Alexandrini, Andrew Abar, Donna Larson, and Anna Wang Mathiasen, pulled a 36-hour shift. So they had already put in a full day when we heard that the transplant was about to be done. They stayed on board, and they continued for at least another 24 hours. So they worked nonstop for nearly 36 hours so that we had continuity of care. And this puts it into perspective as to the spirit of this program, that it's really about the patient, and everybody was going to go full force and to their limit to ensure that we had success for Emily. I'm going to recognize somebody very special, and that's Erin Kaur. Erin is really the glue that has kept everything together. Erin is the transplant nurse coordinator. And if you could give out a VIP award, it would certainly go to Erin, because she has been taking care of Emily from beginning to end. In fact, this morning when Emily wasn't feeling a little bit well, her mother mentions to me, I think she feels more comfortable with Erin than me. And I think that puts it all into perspective. And finally, somebody that I really want to mention is Nick Fiduska. Nick is the quality control manager for the transplantation services, and he volunteered to be the perfusionist for this operation, such that he came, he coordinated everything, and was able to preserve this wonderful gift, this hand that was donated by this individual's family, and preserved it really in a very professional way. Finally, there's a saying, the hand transplant surgeons put the hand on. The transplant medicine doctors keep it on. And the therapists make it work. So we have some of the best hand therapists in the world, and they're sitting in the front row. And I'm going to recognize them. It begins with Betty Werner, Parivash Kashani, Arlen Lowe, Stephen Aguilar, and Renee Portenier. So they are spending almost 8 hours per day to make the hand work that we've put on. It's going to require that much effort. The muscles have not worked. They've become weak. They have foreshortened, so they need to get them back to where it normally was. So they're really putting in the effort, and they're making us look good. Finally, I want to introduce to you my partner, and that's Sue McDermott, who is really one of the world's experts in transplantation medicine.
Thank you very much, Cody. Well, this is certainly a very exciting day for UCLA, and I share Cody's sentiments that to be part of this team has been a great honor. I just want to make a couple of comments that I think Dr. Busatil has already addressed. It is absolutely true that although today we're sitting here and we feel that UCLA has achieved a real milestone, none of us would be in this room if it was not for a donor. There is no transplantation without a donor. And so that donor family that had the incredible grace to agree to donate during one of the most critical times in a family's life is a hero, that donor and that family. And I think we need to always keep that in mind. But more importantly, or as importantly, is that the organ procurement organizations are the conduit that make the gift of that donor family a reality for the transplant patients, such as Emily. And I often think that the OPOs are never quite given the limelight that they deserve in this critical process. In fact, the very first meeting that Cody and I had when we were putting together our team was with our local OPO, One Legacy. We felt that it was critical that we develop a protocol that left absolutely no stone unturned to provide the absolute best in procurement medicine and science, and also with a focus on the compassion that would be needed to ask a donor family to donate a visible, intimate part of their loved one's body. And so we developed a protocol which we feel is our best attempt to address that. And it was our great fortune that our neighbors in Southern California, Life Sharing, and they are sitting here in the front row, and I'd like to acknowledge Jill Steinbring and Sam Oliveros, who were able to embrace that protocol and say, let's do this. And literally within 16 days of our looking for a donor for Emily, Life Sharing in San Diego was able to make possible this great gift. And so, as it is Donor Awareness Month, we should pause and think about the gifts that have been given to us. And I think as the trustees of the public trust, when it comes to such a sacred thing as donating part of a loved person, we should honor all of those families, both in the past and in the future. So having said that, I would now like to introduce a very special person, and this is Emily Found. Please, Emily, would you come up? Emily is an example of what I call the will to overcome. She was dealt an extraordinarily difficult situation as a young woman in the loss of her dominant hand. But she had the will to overcome this. And we felt it was our obligation at UCLA to be able to provide to patients like Emily, who had that will to overcome, the ability to be able to have a new hand. And to have her sitting next to me today is a great honor. And she is a remarkable young woman, and we are very proud that she has had the courage to come to UCLA so that we could give her a chance to be able to hold the hand of her little daughter again. So here is Emily.
Hi, I'm Emily Fennell. I lost my right hand in a car accident about 5 years ago. But before I get into my story, I want to make sure that I thank the donor family. The gift that they have given me, I am truly blessed, and I can't thank them enough. I also want to thank the UCLA team for everything that they've done for me, the surgeons, the nurses, Erin Kaur, the transplant coordinator. She's literally become a member of my family. I can't thank everybody enough. I couldn't have picked a better team to go through this with. Last summer, I decided to look into the hand transplant program. I've done many research things on it. I've read everything on the internet that you can possibly read, and I decided that the opportunity to make myself whole again outweighed the risks of any of the immunosuppressants that I'd be on. And that brings me here today with this team, and they've given me a gift. They've made me whole again, and I can't thank anybody enough for this opportunity and this gift.
Thank you very much, Emily. I just want to make sure that we all understand that The context in which we have approached this at UCLA is in the context of a clinical trial. Emily is our first person in the clinical trial that we have devised. We felt it was very important that we approach this endeavor in a strictly scientific and clinically transparent way. So this clinical trial is designed to not only offer the proof of principle of the surgical procedures, but to also to study the safety and the effectiveness of the drugs that Emily is taking, as well as the return of function in her new hand. Our institutional review board has looked at our protocols, and we have thought it very important to be completely transparent, not only within our own institution, but to the public in terms of what we are doing here on this new frontier. And Emily is a wonderful person to be our first candidate in this trial.
So I forgot to thank one group, and I need to do that, and then let's open up the floor to some brief questions. And the group that I really forgot to thank is the team of the psychiatrists, who's led by Dr. Lisa Moreno. Psychiatry is an important part of this procedure, in that we need to make sure that the patient is comfortable, understands the operation, and is really taken care of in the post-operative sense. So let's open up the floor to some brief questions.
My daughter is 6. She's in kindergarten, and she has been able to touch it. I was able to go home last weekend and visit her. And in her 6-year-old world, she doesn't have more adequate language to describe it, but she says, "Mommy, it's cool."
What was that like for you?
It was incredible for me. You know, I had my accident when she was only 14 months old, so she's never known me with 2 hands. So for her to think that this is cool and for her to be supportive of the decision that I've made is very important to me.
And Emily, how does it physically feel having this new hand?
I can't actually feel it yet. That I won't have sensation for close to a year, but it's right now it almost seems surreal that I didn't have a hand for those 5 years. I do feel like it's mine slowly but surely. Every day it becomes more and more mine. I think once I have sensation in it and I can feel it and I can function with it more, it's going to feel more and more like mine.
And with typing, I read about you're looking to advance your career. That's one reason you wanted to do this?
Yes, right now I can type 45 words a minute with my left hand. I look forward to being able to type with my right hand now and advance even further with that.
I think the chuckle is nobody else can do 45 words with 2 hands. But that also shows you her determination. Why Emily became a candidate, in my opinion, was I felt early on that if I told her you can't do something, she was going to prove me wrong. And that's the exact type of determination we need for somebody to be a pioneer in medicine. Emily's a pioneer. She stepped into a brand new frontier in medicine that's called reconstructive transplantation surgery. So she needs to be recognized as that. And it's the exact spirit of those frontiersmen that she has and those pioneers that made her the ideal candidate.
Right now I'm an office assistant for the county that I live in. I'm going to stay in that position for probably a while longer, but there are other career opportunities in the county that I work for that I'll probably go for. I haven't chosen a career path yet. I'm not exactly sure where I want to go or what I want to do just yet.
So far, what are the things you can do with your right hand?
So far, I can wiggle the fingers, and after I'm in hand therapy for a few hours a day, I'm able to pick small objects up with my hand.
Will everybody be eligible for a hand transplant, or do you have to have something specific?
Well, everybody is not. The question is, would everybody be eligible for a hand transplant that doesn't have a hand? Is that your question? Yes. And the answer is absolutely not. Hand transplant is not for everyone. It's for those unique individuals that are healthy, that are recovered from the trauma of their injury, not only physically, meaning that the wounds have healed appropriately, but psychologically they don't have a stress disorder or other conditions that happen once you have major injuries. Additionally, they need to have tried prosthetics for a minimum of 6 months to be eligible to be considered for our program. So if a prosthetic works for an individual, there is no reason to do a hand transplantation. Yet there are those individuals that say, this is not enough. I need more in my life. This is my only life, and I understand the risks and the benefits, and I wish to pursue it.
I think that the most important risk of transplantation and hand transplantation as well is the long-term need for immunosuppressive therapy. This is a conversation that Emily and I had probably an hour and a half long prior to her ever agreeing that this was the right thing for her. Immunosuppressive drugs, of course, are essential to be able to preserve the graft and the function, but they do carry their own set of risks, and we felt it was very, very important that we were crystal clear with Emily about the immunosuppressive drugs we would use and the kinds of side effects that she might experience. After all, it's a little bit different if you're receiving a heart or a liver transplant. These are life-saving organs. Her hand is a life-changing organ, and she needed to understand that risk-benefit ratio for herself as to whether she would be willing to go forward in life with the use of immunosuppressive drugs. Having said that, one of the goals of our therapy for Emily and for other patients that we would treat is to find that balance between how much immunosuppression we need to prevent rejection and how little we can use to try and decrease the side effects. And finding that balance is something that we have been endeavoring to do for more than a quarter of a century in transplantation. So for her, it's especially important, and she was very understanding of this risk, and we would have not gone forward with Emily if we felt that she didn't fully understand that risk. It's a very important point that you're making.
Why did you decide to take that risk?
I decided that the benefits outweighed the risks. I decided that being made whole again outweighed what could possibly happen to me because of the immunosuppressants.
The side effects that we are particularly concerned about are always infection. Infection is the one shadow that always falls over anybody who's on any kind of immunosuppression. Luckily, we have been very lucky with Emily so far. She's had no evidence of any infection, but that's something that we'll continue to watch, and we will provide long-term follow-up for Emily, not only for the risks of infection, but some of the other side effects. We watch for kidney dysfunction. We watch for any evidence of malignancy. And that is why the commitment of the transplant program here at UCLA for all of our transplant patients is long-term follow-up. You cannot just transplant a patient and say, have a nice life and we'll see you in another 10 years. The commitment to that follow-up to protect the patient from any side effects from immunosuppression is very, very important.
How does she start having movement once the hand has been implanted?
Well, once the transplant happens, the tendons are connected to the proximal muscles, meaning the muscles of Emily's hand of her forearm were still there. So we connected the donated tendons to her native muscles. So those have to be stretched. They have to be placed in perfect harmony with the tendons in the palm side and the tendons in the back side of the hand. If those are not put back together in absolute perfect harmony, in perfect balance, then the hand won't function.
Well, I would like to thank all of you all, but before we adjourn, I'd like to certainly thank Emily and her wonderful family for the courage and enthusiasm to make all of this happen. And the wonderful transplant team, both sitting up and are down here, for making this truly happen. Thank you all very much.